running. Up in Tulsa, we're running it we're actually running it in 2 clinics through OSU CHS. We've been doing it for about 2 years now. And it's definitely a rapidly growing program that's our team has gone from 1 care manager to we're trying to bring on a 3rd one. We're going to hopefully expand to a 3rd clinic, which we're really excited about. Within my program, our goal is 1, to be able to bring mental health services into a primary care setting and make it as accessible as possible, especially for those vulnerable populations that we focus on serving, and reduce that time of people who are getting behavioral health referrals are having to wait 4 or 6 months. If they're going to the OSU clinics, it could be up to 2 years, to drop it down to 2 days, and really get that access and resources to them as fast as possible. And a huge goal of our program is sustainability and expanding a program to something that can be really in place and grounded and be able to bill for those patients. And through being an OSU program, we're really involving a lot of our residents and trainees. So not only build a program up here and have a really sustainable program, but also be in a position where we're educating our future providers so they can take that information and knowledge out to wherever they're going to be working. So we have those family medicine residents who are participating in that collaborative care and then going out to hospitals or wherever they're going to be working next, maybe in rural communities, and being able to share that information. Excuse me. As a state, so we are actually the first ones that we know of that are really running collaborative care in Oklahoma. It's definitely happening nationwide. We actually recently in May went to a conference, a University of Washington collaborative care conference. And it's really great to hear what other people around the nation are doing with collaborative care. And I think that's something we really hope for the state of Oklahoma, for it to not just be us who are bringing those mental health services into that primary care setting and spreading it across the state, especially in rural communities who just have such limited access to mental health services. And especially where it's going to be really hard to access those psychiatrists and psychologists and counselors, really bring those resources out to the rural community. So I think our goal is to really get ourselves grounded in it, but also really get that information, the program spread to other providers in the state. Did that answer the question?
Yes, thank you very much. Well, I appreciate that. And certainly you can reflect once we have all of our panelists reflect too on that. So,
absolutely. Hi guys, I'm Allie Friesen. How's the energy? Are we for the 3 o'clock nap time? I'm trying to think about it with my toddler.
Yeah, everybody stand up, right?
Yeah, we all wish we had toddler nap time still. So yes, I'm Allie Friesen. I'm the director of the Behavioral Health Clinical Program for Integris Health. So that is our service line structure. That was a part of our new operating model that came into, existence in July of 2020. If you recall, there was a lot happening in July of 2020. So why not throw in a new operating model on top of it? So I'm a clinician by training. Never in a million years did I think I would be in a leadership role, but alas, here we are about 3.5 years in. So our role in clinical programs is to drive evidence-based care, to drive care standardization, cost-effective care, and smart growth strategies. So as you can imagine, we live a lot of time in the smart growth realm. We're very heavy in how do we optimize the resources that we have, and then how do we develop an effective business strategy for the growth that we do need as a system. And I think I can speak confidently with this group that we all are hurting for resources, whether it is frontline RNs, whether it's techs, whether it's specialty licensed mental health professionals, specialty physicians. We are all scrounging for the resources we need. I think from a state perspective, what I would like to see is almost, forgive kind of oversimplification, but almost a collaborative care model, just kind of blown up across the state. And what I mean by that is an increase of coordination. So Dr. Hubbard and I have talked about this many, many times. We have so many pockets of greatness across the state, and we do have pockets of pretty plentiful resources, but we're not communicating with each other very well. It's certainly improved over the last few years, and I'm happy to see the engagement, not just from, a governmental perspective and a fiduciary perspective, but also from just the general community interest. But I think that's something that as licensed mental health professionals, as medical professionals, as administrators, we need to capitalize on that and figure out as a structure, as a system, at the state level, how do we better organize ourselves to communicate and to optimize the resources we have? So in my mind, that's what collaborative care is really good at, right? It is, let's make sure that we are identifying the patients who need the help and that's appropriate for this level of care, and that we escalate them to whatever escalation point we need to. If that's the psychiatrist, if that's a more emergent situation, it allows us to have those points of contact. So a lot of my time is answering distressed phone calls from physicians, whether it's in the emergency department or whether it's in the primary care setting, saying, what am I supposed to do with this patient? And a lot of those are very complex cases, behavioral disorders, suicidal patients, distressed family members, and that will continue to happen regardless of what we achieve structurally as a state. But we have to allow our fellow medical professionals and citizens across the entire community, whether you work for the state, whether you're the Department of Mental Health, or whether you are in private practice, we should know what levers are available to us when and how to call upon the appropriate level of help. It shouldn't be this challenging for us to navigate the system of mental health. And, typically in a health system, you work with fairly well-educated people, right? And there are so many questions that I receive as to how do I even find a counselor? How do I find somebody that I can see within 6 months? And OKCapMap has been an incredible resource that I send a lot of physicians to utilize what we do have again, but there's got to be a better way.
Have you had the opportunity to use the 988 system? So you have your clinicians?
Yes. And if I can be candid, there have been positive reviews and there have been negative reviews. Mm-hmm. So I think in certain instances, it's very helpful. But I think, again, it's the same issue across the private sector as well. It's the follow-up and we de-escalated the crisis, which is certainly an enormous stride forward. However, what do we do next? And I think we run into the same challenges of, I called and they can't get me in for 6 months. Mm-hmm. Well, I was given a list of phone numbers and 3 of them were disconnected, right?
Right.
So it's building out that care continuum in a more robust manner, which to the credit of 988 and our public partners, this is a huge step. And I think there's a much larger plan coming to fruition.
Great. Traci?
Hi. It's good to be in a room full of so many great experts, especially lots of experience in integration and behavioral health integration. I could talk about integration all day long. It is my huge passion.
Yeah.
10 years ago, we implemented behavioral health integration in our primary cares at OU. I was the first one here at OU, which at that point I thought this is going to be a career ender or maybe one of the greatest things I've ever done. And it has been one of the greatest things I've ever done in my career. And since then, we've been able to put behavioral health clinicians in all of our primary cares on campus, our women's health clinics, because as we know, women, I would use my OBGYN as my primary care doctor as long as I possibly could. And so we thought that was a great place to address, postpartum mood disorders and things that affect mental health disorders that affect women. And then we've expanded into our pediatric clinics as well here on campus. I think to touch on your coordination of care, I think that's
probably a huge challenge. One of the neat things in my career, we've been able to partner with Integris and St. Anthony's. We have a collaborative group, the Primary Care Association, a collaborative group of clinicians that meets every other month, quarterly, to share best practices and problem solve about behavioral health integration. These are clinicians that are doing the heavy lifting every day. And it can feel very isolating when you're the only behavioral health person in a primary care clinic. And so it's just so great to have colleagues that are doing similar things, compare notes with what's Integris doing to solve this problem, or what's St. Anthony's doing to solve this problem. So that's been a really great bright spot in integration, I feel like. But I think, moving forward, and I'm so sorry I did not hear the morning, but I think one of the things we need to move forward as a state is the collaborative care model using the Medicare codes, the Medicare billable codes. I think obviously there aren't enough psychiatrists to go around. And having that model of care, we've implemented it very slowly at OU. I think it's challenging because if you are a health system that pays physicians based on RVUs and not quality of care, it's a really hard fight, because the primary care and then the psychiatrist, who's going to get the RVUs for this collaboration? So I think we really, as a state, have to shift our thinking around value, around volume-based care to true value-based care for integration to really fully express itself well. And then I think we definitely need this model that we've implemented with primary care in our pediatric clinics. I don't think there's been very many pediatric clinics that have adopted this integration model. We have one. It's amazing. That clinician is very busy. I think we prevent a lot of kids ending up in the hospital. I think we prevent suicidality. It's just this very unique opportunity to catch things before they become really big issues at school or in families or in society. So I think those two areas are probably where the state could benefit from growth in integration.
Well, thank you so much for your perspective. And Frank.
Well, from the ER side, it all seems a little different. It all seems like all collaborative care ends up in the ER.
Yeah, by force, right?
And Dr. Dial, you hit it right on the head. We have no plan for suicidal patients. Once a patient comes in and says they're suicidal, you go down this rabbit hole and you never get out. And they all sit there, you're right, for days waiting. And if they turn around and say, well, I'm not suicidal now, it's like, well, too bad. You already said that, and somebody's filled out a form, and you're just done. The patient is set there. And it is really sad, because we don't try to figure out who is just kind of thinking about it and who really is wanting to do it. And we know the difference. You can see a patient and you can tell who's really serious about this and who just wants a turkey sandwich and someplace to go to get out of the heat or the cold. But once it's started, there's no way to stop it. And I do think that we have to have some other way to kind of look at this and find a different way. I love the idea of this collaboration where we could get people to get somewhere else for help instead of having to reach to the ER. But I understand the other side too, is there's nowhere to go. If somebody comes to your office or calls you and says they're suicidal, what else are you going to do? I mean, it's just kind of a rough spot right now.
It is. It's a very rough spot. Have you seen, though, any success at all in your setting at St. Francis, where you have and maybe in-house
we do have in-house psychiatry,
right? Or even a care manager or social work in the ER that may have helped coordinate.
Social work does help coordinate to find a place for them, but it's still, you might call them at 9 o'clock and they say, well, I talked to this place and they may have a bed at 5. And so they sit there all day. And you don't know if they're going to get a bed at 5 or not. Or they may say there's no bed, so we have to admit them. And we'll admit them to the hospital. And we do have psychiatry at our hospital.
Right.
So that helps. But also we've got 30 patients sitting in the ER waiting for a bed upstairs. And so
Yeah.
if that person could get treated somewhere else or just be evaluated, and sometimes I have been able to call psychiatry and say, I really don't think this guy needs to be admitted. Can you come and look at him and do an evaluation here in the ER? And a lot of times they'll say, yeah, he does need to be, or they'll say, no, I think you're right. He can go home.
He's safe to go home with close follow-up or,
That's right.
yeah, that type of thing. If there is available close follow-up.
Yeah, right.
9 months. 9 months.
Yeah, 9 months. That's not what we're talking about, the close follow-up. Anyone else want to ask our panelists their perspective, or you all have any other reflection on what, say, Dr. Kate talked about, which, to me looked like an ideal. I would have loved back when I was, just out in practice to have a care coordinator. We've kind of had it a little bit with some of our patients, but it has worked fabulously when it's available, but finding the adequate resources and keeping it there continuously has become, at least my perspective, of the challenge, whether it be in a integrated health system or for folks like Dr. Subera and others who are out in independent practice and trying to coordinate that. And I wonder if there's some opportunity to do some coordination. If we, you talked about, I was trying to think of what you were saying, but taking some of those practices that are not necessarily affiliated with, say, OU or Integris or Saints, but in engaging them into our systems,
Right.
So that they can take advantage, because they only need a little tiny bit of a care manager, but maybe that could be very critical in that patient ending up in one of our ERs at St. Francis, at OU, at Saints, or Integris. That I'm wondering if that may be a way of helping integrate many of these systems, that you're not doing a legal integration, but maybe a clinical integration, or whatever you want to call it. Oh, there is. What was it?
Opportunity for a partnership with the community health departments across the state.
The community mental health. Okay. Anyone want to take that one on? To opportunity, the county health departments, to use them as our coordinators of healthcare. Is that Casey, who's from the State Department of Health?
We did have a partnership with the county health department to do some, they had some community health workers that they partnered with our integrated behavioral health. And that was a really successful model, but it was pre-COVID, and they went into people's homes. That kind of stopped. So I think that was really good. But I think just partnerships in general, we've been able to partner with NorthCare and place iPads in 2 areas on campus that didn't have any access to mental health services, but were high needs. We don't have enough social workers. We don't have enough LPCs. The workforce development is a real issue. So we have to leverage our community partnerships to be able to meet the needs. And that so far has piloted and been very helpful to us. So.
I will say I unfortunately missed this morning, so I'm not sure what all was discussed then, but something that we've done a lot of internal partnerships. So like within OSU, like we've partnered with our health access network, and that's actually where we got our first care manager, was through there. We really had someone in that department who was passionate about collaborative care. So we kind of used him as an advocate for the program. And he was able to have conversations with their director and one of their care managers for the Health Access Network. We ended up splitting her time. So it started out she was doing 90% Health Access Network work, but then as our program was still small, she would spend about 10% of her time with us. And as our program grew, we shifted how much time she was working with collaborative care versus Health Access Network. And that was something we really did as a partnership with them, is figuring out how to distribute her time. Like she's still Health Access Network, but she was able to then transition to 50% collaborative care. So that was, I think, for us, like outside of OSU, haven't necessarily done those partnerships. We are using a grant currently to fund a second care manager. So that's something we've spent a lot of time, is likely for those federal grants, those workforce grants, to help fund that position. So our first one is an RN. Our second one we brought on is through that grant, and he's in LPC, and we're looking at bringing on a third one, a social worker, who would also be through the Health Access Network. So that's something we haven't like partnered with the Tulsa Health Department, though that would be I haven't thought about before. I would love to like explore that. But we've really like brought in those partnerships within OSU and the different departments.
Casey mentioned on a chat that she is now the director of suicide prevention for the state health department.
Oh, really?
And she's looking for partnerships.
Okay.
Well, your cell phone number, ma'am.
Right.
Yeah, that's right. We need her cell phone, Carol. Maybe she heard us. So, but that's certainly something that could certainly be helpful to since health departments are out there, and that interface between primary care and public health has always been a challenge, because they have two different views of the world. Though you would think it would be ideal. That's something that we've always struggled with, I think, in our healthcare system in the United States, let alone Oklahoma. But I think this is an opportunity maybe to help with that. And obviously, working with others in that way could be helpful.
Mm-hmm.
Yes, Dan. Here, look. I'm going to get you the mic so that here.
As I've sat here through the whole day, and it's relived about 50 years of professional life, and thinking that a humongous idea, a huge idea has been presented to this group. And yet I don't believe it's stuck anywhere. I'm not hearing that anybody gets it. Just not hearing that anybody gets it. We worked at OFIC with Jessica and Takia for 10 years trying to do some of this. And what we found out was we have such a cultural gap in accepting the big idea that we can't get it. The big idea that I heard today was that we stop using one-on-one consultations with anybody in the mental health arena, that we use this one-to-many or many-to-one, and that we actually review panels of patients for their outcomes, and that we use outcome-based measures in mental health, like we're doing with blood pressure, cholesterol. And we aren't doing any of that. Some of it here, some of it there, some real good projects, some real good grants have done it. But in the idea that we need to do this on a very broad population base, I don't think we're getting it. First of all, I don't think the right people are in the room. When we implemented SBIRT, or tried to implement SBIRT across some 30 or 40 practices in Oklahoma, what we found out, there was nobody to catch the ball when we sent it downstream. And what we're talking about here today is actually coming up with a solution to that problem. And I haven't heard that anybody's addressed that or thought about it. So I hope, Takia, that the work you guys are putting in with the Zarrow Foundation's efforts will move this issue forward. And it may take legislation and other ways of doing it to get this going on. But has anybody actually worked with your psychiatrists and the people who coordinate this activity to actually develop teams of people who are responding to other teams of people electronically and tracking it and knowing what you're doing?
Yeah, I think so.
Yeah.
Yeah, go ahead. No, please.
I think each health system has implemented it slightly differently, but we're very similar. We have registries that we're responsible for maintaining and following up on, whether it be a depression registry or PTSD registries, social determinants of health registries, creating patient pathways. We partner with psychiatry. We have piloted the collaborative care model here. We two different models, right? We have a collaborative care model, which is sustainable through that Medicare billing code. And then we have our integrated behavioral health model, which is financially sustainable through more traditional mental health billing, implemented in a non-traditional way, if that makes sense. I always say we're using traditional therapy tools, but notice I don't have a couch in my office because my job is to work myself out of a job. So, we want to get people better, faster, and we want to catch them in primary care. We want to prevent them from, a hospitalization, or even prevent them from needing therapy very long term. But I think, piloting the collaborative care model has been challenging just in terms of working with psychiatry. We partner with them, and they provide the consultation model. But again, it sometimes can become challenging in an RVU based system. Oklahoma just really, as a state, has not gone full force with a value-based care. All the health systems, I think each of us have some strengths, but we're still just really in a volume-based care modality. And I think managed Medicaid will definitely challenge and push this model.
I was just going to ask that. What do you think of it's going to start, and we did have a couple of representatives here, and we still do have one that's from one of our managed care Medicaid providers in regards to that. And I think they're very interested in this particular model. Would you agree? Yeah. So it is something that we may have an opportunity because they have an interest, because they understand. And I know certainly the medical directors of at least two of the three plans are well versed in, at least on the primary care side, but understand that issue of integration is very important.
Does your system just take them once they're into the psychiatric side, or is it still primary care doctors still managing?
These are all primary care. Yeah, we really try to only refer to psychiatry if we just really can't manage primary care. Because they're
good for counseling and all. Do they have, you have counselors through their primary care?
Yeah, they can. And people feel really comfortable going to primary care. I mean,
they enter the primary care door, but then they may see a behavioral health a provider within that primary care's office. That's been my experience. But I, again, still am challenged. We have a huge number of unaffiliated primary care providers in our state, and how they get access to this particular care is where I see our managed Medicaid systems providing maybe an impetus and an avenue to help us integrate that and almost encourage that, figure out innovative ways that they can bond or have similar systems. And we've tested it in our integrated healthcare systems. Now, how do we get from there to engaging with our other colleagues out there that are taking care of a huge number of people that aren't in that system, that end up in our system, but at the needing a heck of a lot more care than if we had stopped it before or intervened earlier. Is that, Allie, you were going to say something? I'm sorry.
No, I was going to address the question. It's a very valid question. I mean, I've been in this field for 10 years, actually in clinical practice and leadership, and I get extremely frustrated. And sometimes I'm like, what's the point? Because this problem is so big, but those days are few, and then I say, suck it up, let's keep going. So I think we're working against, in healthcare, we say it's not the person, it's the process, right? If there's a safety event, you have to figure out what went wrong. It's not the person, it's the process.
Right.
In my mind, this is a similar issue. It's not the people that aren't trying hard enough, that aren't educated enough, and that don't really understand the root cause of the problem. I think we all see the root cause of the problem. We don't have an infrastructure that allows us to scale to meet the need across the state. So I think managed care is absolutely, like how you represent managed care. Congratulations. I think managed care gives us an opportunity to get creative, because no health system, how large, no matter what state funding they have, no matter what philanthropic funding they have, no state system can scale in the amount of time we need to scale to stop the trajectory that we're on. So I think there is enormous potential for us to partner, and I don't know what that looks like. That's a giant whiteboarding session, it sounds like to me, to figure out how do we pool our resources that we have. Is it a care network? Is it, a massive float pool that we kind of pilot? How do we separate the days to get coverage across this region, across this county, across this many clinics, so that we can allow our patients that need to see their care managers and that need to be reviewed by a psychiatrist, that they get access to that care. Because we know if we don't get this right on the primary care side, the ambulatory side, we're only going to see those ED numbers get higher and higher. And the biggest challenge, I would argue, being in a leadership position in this field, is how do you do both? How do you ensure you have the crisis systems in place to care for the patients that are taking over your emergency departments? But then conversely, how do you work upstream to prevent even more and more people sitting there for 15, 16 days waiting for a bed? But if we get the upstream intervention part correct, we give ourselves at least a chance to allow those inpatient psychiatric beds to be utilized by those that truly need those beds, instead of flipping that default switch in the ER and saying, well, they need to go to inpatient psych.
I would even say, like, with a lot of what we do, so we, with our psychiatric consultations, I would say a lot of times we even do triage, where we had a lot of residents who were referring to patients to behavioral health and collaborative care at the same time. We're like, no, refer them collaborative care, let our psychiatric and our psychologists consult and look at the patient, and then they can help make that determination. Like, is this someone who really needs to go behavioral health, or can we provide that care in collaborative care and help reduce the number of patients who are adding to that list of patients who are waiting to see behavioral health, when actually we can manage their mental health needs in collaborative care and make it so the ones who really need behavioral health services get added to that process. And then we're still supporting them while they're waiting to get in to see behavioral health. So that's something, like, even with what we're doing, we're trying to reduce that, like, referrals to behavioral health is just adding to the list of people who are waiting to get in to see behavioral health. Like, okay, who can we take care of right here, right now, and get the ones who really need behavioral health to behavioral health.
I don't know other people's experience. The thing about collaborative care is it's beautiful, but when you have primary care physicians that you're telling them they can no longer refer to psychiatry and they need to maintain the prescribing themselves, some of the answers on the other end of that are not very fun. And they're like, I think ours in our first pilot, they were like, I'm just a paper pusher for psychiatry. And so for collaborative care model to work, we have to have an epistemology shift in primary care. And no offense to the older doctors, but the older doctors in our clinics are like, middle finger, get out of my clinic. I'm doing it the old school way. I don't want to change. And so I think in Oklahoma, I think we have to remember that for primary care to do more in primary care, whether it's screening or collaborative care or whatever, the perspective shift is a lot of pressure on primary care to be willing to do it. And they're so tired and they're so overrun. So a lot of time proposing and saying collaborative care is the answer, primary care doctors are going to riot because everything is on them. And so I think you guys have seen that in academic detailing. They just don't want to do another damn thing. And when you talk to them about collaborative care, which means they can't refer to psychiatry anymore, I'll save you some gestures we've been given.
I would have to say that your reflection is true. When we've gone out, and I think it's even more our practice facilitators than even the academic detailers in our Oklahoma Primary Healthcare Improvement Cooperative, and trying to just get people to implement the expert tool. The issue is the tool's, relatively okay, but then, what do I do with the data that I just got, particularly if it means this patient needs, a referral to where? I don't have any referral to where available in that setting. And people go, I don't want to do that anymore because it just makes me feel very uncomfortable. And then, we can add this collaborative care model. And now I did know that a family physician that I've known for many years, older, he fell in love with having a mental health provider co-located in his practice, and died if that person was not going to be available, because he found it so valuable to care for his patient. Isn't that right, Traci? You know who I'm talking about.
That story. I do know that story.
Yeah. And so I do know that having that collaborative care model that Traci and her cohorts implemented in an OU Health Clinic was very powerful, because it seemed, by having that physical presence, offloaded a bit of that stress in many ways that you were adding. It seemed, even though that may have added a bit more things that they had to do, it gave them somebody to kind of offload the emotion to. I think. What do you think, Traci?
I think it frees the primary care doctors up to focus on the things that they focus on best, and allows the mental health provider to focus on the thing that they're trained in. And I think it's the perfect marriage. But I do think, Shannon, you're right that, especially the older, all providers can really be vested in it, no matter what age. But if you're used to practicing a certain way, you're just in your flow through the day, and you might go, "Oh man, I should have introduced them to Traci, but I forgot, and they already left." And so for me, it took a good 18 months. I always say it's a good year for a clinic to really adopt the model and get used to having somebody there. And it's a real culture shift. And it's a culture shift for a behavioral health provider too, that not everybody, I wasn't trained in this model, and not everybody, wants to do this kind of care too. So it's a shift for everybody, but my gosh, it's really a great model, and I can't imagine practicing another way. So
I will add,
yes. Go ahead, and then I'm gonna.
Sorry.
No, go ahead.
I will say, for our clinic, they still do behavioral health referrals. What we've done a lot of training with the residents is when they're on the fence and they don't know what to do with a patient, that's where we get to come in and take that stress of uncertainty. And with, I would say 18 months, it's like exactly a year to 18 months is about how long it took us to create buy-in. And we had to spend a lot of time training, but our training was creating that buy-in and finding our champions to help advocate internally. Because we definitely have providers who they wanted nothing to do with it. So we're like, okay, that's our champion. Finding someone else to kind of support that. But yeah.
How did you guys make the decision as to which clinics to pilot the collaborative care model with?
That's a good question.
Sure. Well, I can speak for our clinics first. Before my time in leadership, when I was working as a clinician at Integris, they started the program through the CPC Plus program, and I think based off of that criteria, that led them. Yes.
The true collaborative care.
Then I'll let you take that, because we're there. We're working on it.
I think it's always having a physician champion. Having the three for sure, but having that physician champion that says, my patients would really benefit from this, and let's, just be willing to try it. I think, I think you have to look at lots of different aspects, but the physician champion is probably the key, and the culture of the clinic, and the payer source, of course, because you want to make this is, if you pilot it, you want to make it last. You don't just want to try it and it fizzle through. But setting up
Site, or did you pick one site that you're doing the collaborative care pilot in?
Yeah, and it's not been perfect. And we wanted to try it in oncology. It doesn't necessarily, the collaborative care model doesn't, the intention of it is for primary care, but you could use it in another environment where somebody's getting a long episode of care, like oncology. And so we looked at there, but it's just been hard to take off, but definitely looking for the right culture and a physician champion.
Sorry.
Go ahead, Allie.
I'm just going to add to the payer component that it's helpful, to your point, to reach sustainability, to partner with kind of the payer strategy in the system. And if you do have lives that are at risk, that's going to get you more buy-in from the administrative perspective and say, these are the outcomes that we are planning to achieve, having those quality metrics in place. And then you're working with the payer and saying, this is how much money we've saved you. Give us X amount of dollars for next year. We're going to do even better. So it's finding that good niche and that good partner that's ready to dig in.
I think we're at a cusp of a point, hopefully, that'll be positive. One, there's the new codes that the Healthy Minds Initiative have advocated for that we can use that will help the payment system catch up with what we want and need desperately in our healthcare system. And at the same time, we have the managed Medicaid. Medicaid's a huge part of our healthcare system in Oklahoma, and help transform, because you don't, even if you implement it just for your Medicaid patients, hopefully most will get it into their mind that they see their patients irrespective of their payer source and treat them the same way. And hopefully our commercial insurers will catch on to that same effort that Dr. Kate mentioned when, at least the ideal is that process will transform. Now, it may take not just 18 months from whenever all of that occurs. November 1 supposedly is what that new code goes into place, right? The key is, to the issue of managed Medicaid. I believe that starts enrolling next July. Is that right? When? April. You go live April 1st. So there is people watching over. The healthcare authority has a quality committee. And maybe they'll be also watching this effort, I imagine, and each of the systems have their own quality committees that'll be watching that. And I know that they're challenged to not only obviously be fiscally sound, but also clinically sound. So we're going to be excited to see a grand transformation, and you all are going to be all at the forefront of that. Everyone that's probably part of this, and I think we're talking about, and I say, I guess we're looking at the future and trying to see what's out there, and it's going to be exciting, hopefully good exciting, not bad exciting. So, but we keep our fingers crossed, but we're also part of the solution. I think every one of us is, and that's what we hope will foster this discussion and other discussions within your systems.